Hello, in this video, I'm going to talk about acute coronary syndromes and exercise recommendations. So cardiovascular disease, if we just start with a broad overview, that includes coronary artery disease, which is what I'll focus on in this video, heart failure, hypertension, and stroke. So cardiovascular disease and all of the pathologies that fall under that category are the leading cause of death in the US for men and women and accounts for about half of all deaths. So we can do all sorts of things to reduce our risk of cardiovascular disease, like reducing total cholesterol, reducing blood glucose, reducing blood pressure, smoking cessation, and exercising and eating healthy, which of course will also impact all of the others on the list. So what is coronary artery disease? So the coronary arteries are the blood vessels that supply blood to the heart muscle itself. So the heart has blood that is filling the heart so that it can be pumped to the lungs to be oxygenated and then be pumped out to the body to deliver that oxygenated blood. But we also have to have that nice, fresh oxygenated blood being delivered to the heart cells itself to keep the heart healthy and functioning. So the coronary arteries are supplying that blood. So if we have damage or disease in those coronary arteries that's interfering with that fresh oxygenated blood being delivered to the muscle cells, to the heart cells, then we're going to have death of those cells or pain from those cells from the ischemia or the lack of blood flow. So coronary artery disease generally involves buildup of plaque in the coronary arteries. And so as that plaque builds up, it narrows the lumen of those vessels and could eventually completely block those vessels, which would obstruct the blood flow from being able to get to the heart to supply it with oxygen. Atherosclerosis is when the lumen of an artery narrows due to the plaque buildup. So everything I just described is atherosclerosis of the coronary arteries. Arteriosclerosis is when we have thickening or hardening of the artery walls. So when that does occur, it's usually in older age, but older age does not mean everybody has arteriosclerosis. So if it happens, it generally happens in older age. So atherosclerosis risk factors, so tobacco use, obesity, dyslipidemia, metabolic syndrome, hypertension, family history of premature coronary disease, diabetes mellitus, being male, men are more prone to atherosclerosis than females, sedentary lifestyle, and obstructive sleep apnea, which most commonly occurs with higher BMI. So it's possible that obstructive sleep apnea isn't actually the risk factor, that it's really obesity or higher BMI that is the risk factor causing both the atherosclerosis and the obstructive sleep apnea. But it's still listed here because when somebody has obstructive sleep apnea, they're more likely to have atherosclerosis. Therefore, we list it as a risk factor. So what are acute coronary syndromes? So that includes unstable angina pectoris, acute myocardial infarction, and sudden cardiac death. So angina pectoris is chest pain. So there is stable angina pectoris. So like if somebody has had chest pain over time, they're having it chronically, but there's sort of a pattern and it goes away pretty quickly. Yeah, I mean, the pattern and going away quickly is really what makes it stable. Unstable is when it lasts longer than it should, or it doesn't fit the normal pattern, like it happens in a context or scenario when the person's chest pain doesn't normally occur. So maybe they only get chest pain if they exert or if they exert too much. And then when they stop, then it goes away. But maybe this chest pain is happening even at rest and it's not going away. So it's not following the normal pattern. So that makes it unstable angina pectoris. So sudden chest pain or tightness, and it worsens very quickly. This is a medical emergency, especially because the symptoms are pretty much the same as in a myocardial infarction. So you can't really tell without seeking medical attention whether it is actually a myocardial infarction or unstable angina pectoris. And unstable angina pectoris is a warning sign that a myocardial infarction is likely coming. So an acute myocardial infarction, that is a heart attack. So that means that the blood vessels, the coronary arteries that are supplying blood to the heart itself, have been occluded, or at least some branches have been occluded, but some part of the cardiac muscle cells are not receiving blood. And so that's called ischemia. They're not getting enough blood flow. And then that causes necrosis, which is death of cells, because they are not getting the oxygen that they need. So a heart attack, it can be small, depending on the size of the vessels, or large. So if a very large vessel is occluded, then that means that blood flow to a large section of the heart will be blocked. And so a large section of the heart cells will die, versus a very small artery might not even be noticeable, or it could be a lot more minor, a lot less severe in signs and symptoms, because it's a smaller amount of blood going to a smaller number of cells that die as a result. And then sudden cardiac death is death that occurs due to coronary artery blockage. So acute myocardial infarction means that blood flow is blocked to part of the heart, and it may or may not lead to sudden cardiac death. So these two things are very related. So myocardial infarction might cause sudden cardiac death, but they are not the same thing exactly. So exercise recommendations following myocardial infarction. So for somebody who has had a heart attack, these are the recommendations. So there's really two goals of exercise for somebody after a heart attack. For one, it's that we want to prevent another heart attack or some other cardiac event. And then two is that we want to get this person on a regular exercise program that they can adhere to and stick with so that they can continue to prevent another heart attack. So they should be exercising 4 to 7 days a week. Now, they might have a pretty low exercise capacity when they're first starting. And if that's the case, then 4 to 7 days a week is good, but you might want to have them exercise more than once on those days. Like if they can only do 5 or 10 minutes at a time, that's a great place to start. But doing that once a day, 4 days a week is not going to get them very far. But doing it twice a day, 5, 6, 7 days a week is going to have a much greater impact. And working at doing such a short duration is going to be safer for that person who has a lower capacity. And then you want them to work at an intensity at about 11 to 16 rate of perceived exertion, or 40 to 80% of heart rate reserve. So you want to be cautious. So start low, start easy, and kind of see where they're at, see how they tolerate it, see if they have any kind of cardiac symptoms as you're working with them. So start low and very gradually progress and work your way up within that range. So you want to start with them with 5 to 10 minutes at a time. And again, you might want to do that twice a day, several times a week. And then over time, you want to progress to 20 to 60 minutes at a time. And then once you get up to those higher ranges, they only need to do it once a day. On whatever days they're exercising, and gradually increase by only 1 to 5 minutes per session. And so do it proportionally, depending on how they're tolerating the exercise and whether they're having any kind of symptoms or anything like that. So you might start with 5 minutes at a time, and they might do that twice a day, every day. And then you might go to 6 minutes at a time for the next week. So go as gradually as you need to. Don't be afraid to go slow. It's more harmful to go too fast than it is to go too slow. And then what type of exercise? Let them do whatever is their preferred aerobic activity. Remember, the goal is adherence to a regular program. So the more the patient enjoys the exercise that they're doing, the more likely they are to stick with it. So if there's exercise they can do that has some kind of social benefit, like they could do it with their friends, or it's a sport they can play or something, or if they like to be outside, let them do something outside. So just get them doing whatever they're going to enjoy and continue to do. So after about 2 weeks into their training program, then you can start to introduce a little bit of interval training into their sessions. So you don't want to do that in the first 2 weeks, because first you want them to just adjust to doing aerobic activity at all. And then 2 weeks in, then you can start to add intervals. So you want to start with just short 30-second intervals, gradually increase over time to 1 to 2 minute intervals, or even longer, depending on their tolerance and their level of fitness. And you want to do this 2 or 3 days a week. So what that means is not every single aerobic training session will include intervals. It means that only 2 or 3 times a week, you're going to include intervals, and you'll still have the other days of aerobic exercise where it does not include intervals. So if this is a training client that you're working with, you might give them the homework of doing kind of their steady state aerobic exercise on their own and do the interval training with them together for your sessions where you see them. Okay, resistance training following myocardial infarction. So the safe guideline is to wait 5 weeks into their training program before you add resistance training. So that is the standard recommendation. There may be some cases where you could start them a little bit sooner than that, like 2 to 5 weeks into their resistance training program. I wouldn't start them on intervals, aerobic intervals like we just discussed, and resistance training at the same time. So I would at least wait until the 3rd, 4th, 5th week before adding resistance training, so you're not adding too many new things all at once. But 5 weeks really is the safe part of that range. It's really the safe recommendation. So if you are in doubt and you're not sure what your patient can tolerate, wait until 5 weeks into your aerobic training protocol. But then add in your resistance training. They should be working at an RPE of about 11 to 14. Start them with 12 to 15 reps per set at about 30 to 60% of their 1 rep max. You should not be doing a 1 rep max with this patient because you don't want to push them that hard, but you can use other methods to calculate and find those percentages. And then you want to gradually work them towards heavier weights and doing only 8 to 12 reps per set. So 60 to 80% of 1 rep max. And they should be doing 8 to 10 different exercises per session. You want to do it 2 to 3 sessions per week, and that's on top of their aerobic exercise training. Avoid the Valsalva maneuver. So that's where we're increasing our intra-abdominal pressure. So you kind of bear down to lift heavier weight. I don't recommend that for anyone really, because it's not really great for any of us to increase the pressure like that. And sometimes we don't know who is necessarily at risk of some kind of cardiac event or stroke until it happens. So I would avoid for everyone the Valsalva maneuver, but especially in somebody who is a cardiac patient, they should not be increasing their intra-abdominal pressure. And then you can, as they get more comfortable with their resistance training, you can add in some high intensity interval training during each session. So just like with the aerobic intervals, you want to start with short 30-second intervals, maybe 3 to 5 times per session, and then gradually build up to 1 to 2 minute intervals. All right, that's all I have for you in this video, and thanks so much for watching.